Anyways, I'm going to, I'm of another vintage, I guess. I'd like, just out of curiosity and knowing a little bit about my audience, how many of you were born in the 1920s? Would you raise your hand? Yeah, I didn't expect a lot of hands going up. How many of you were born in the 1930s? Raise your hand. How many of you were born in the 1940s? Okay, and the 50s? Yeah, okay. Just interesting a little bit. Well, I'm actually of the pre-era of slides. And I remember when, as I got older, I saw the dominance of slides and how helpful they were in patient education. I remember when I was in San Francisco at Moffitt Hospital. They have a Moffitt Hospital in San Francisco, which is their best for the University of California. It has nothing to do with the local Moffitt. The local Moffitt is a totally different origin, so they're not related at all. But it was interesting. It was one of my jobs as a fellow to go pick up some of the speakers. And we had a very prominent speaker from in gastroenterology, which was my special field, from Michigan. And I was to pick him up at the airport and help him get situated with his hotel room and so forth. So I picked him up and we got to his hotel room and he says, "Oh, wait a minute, where are my slides? My slides." And he said, I can't give this talk without my slides. So I said, I'll go back and try to get your slides at the airport. I'm sure they're there somewhere. But he absolutely panicked, which I can understand. But the idea that he could not give a talk without his slides really amazed me a little bit. But anyway, so I'm going to get started. I go way back, as I said. I'm in the late eras of the 1920s as far as my birth. But anyway, and when I was only about 5 or 6 years old, I developed an enterococcus infection of my throat. That's the same type of infection that President George Washington died from. Actually, in a way, George Washington died of too many physicians. But at any rate, so I developed this infection in my throat. Of course, I didn't know much about it. And I was an only child. And my mother had to give me some liquids through simply a straw. I mean, I couldn't swallow anything. I couldn't even have a good swallow of a fruit juice drink or something like that. And so I was going to die. And at that time, our pediatrician, who was one of the prominent pediatricians in South Tampa at that time, where I grew up, and that was Dr. Coward. And of course, they made house calls in those days. And so he came, and my temperature apparently was running 105, 106. And I would have episodes of, delusion and so forth. And so I could hear him sometime talking to my folks outside in the hallway. And he said, "I don't think Joel is likely to make it, but there's a new medication that we just got. It's called sulfa. And I'm going to get some for him and bring it to him and see, hopefully he might have a response, which would mean that he's going to survive." So he brought the sulfa solution, and it was given in a liquid form, mainly through the straw, and so forth. And in a couple of days, my temperature went down, and of course I survived. But it's interesting that in Tennessee, they wanted to, I forget the name of the pharmaceutical company that was very prominent in Tennessee. They wanted to start and introduce sulfa, but they diluted it with the same alcohol preparation that's present in brake fluids in cars. And about over 100 young children died from that toxicity. So it was just a trip back to show how physicians usually, very often in sick patients, they would actually come and visit at the home. And when I first started practice, I thought, well, I would make trips to the home, and I did it for about almost a year. And it was not economical for me. I had trouble finding addresses and so forth, but I did learn a lot about patients that I would not have learned otherwise. And I have some interesting examples, but I won't go into that right now. I'm a Tampa native. I grew up here, and I did the Trinity of South Florida. I went to Goree primary school, and then junior high at Wilson, and then Plant High School. And anyway, so I went to the University of Florida as a pre-med student. And interestingly enough, Florida had no medical school then. And so everyone had to apply out of state. And I had an unusual situation where my parents knew I always wanted to go to Europe to visit, and so they gave it to me as an award for graduating from college. And there I happened to meet, just by chance, a group of medical students from the Lausanne, Switzerland. And we got in a conversation, and I explained my problem, that Florida had no medical school, and I had applied to several, which is another story. Anyway, I ended up going to medical school in Lausanne, Switzerland. It's 1 year longer there. They have 5 years instead of 4 years. And of course, I had to learn French. I'd had 1 semester of French in the University of Florida, which meant I couldn't do anything. But it's amazing how you learn rapidly when you're forced with that. And they did not believe in giving monthly exams or things of that sort. They thought that was childish. And so in the medical school, they only gave 2 basic examinations, and one at sort of the end of the preclinical period, and then the very last one when they had a final exam. And in the final exam, it lasted over a month, and the periodic oral examinations. But at any rate, so that's where my background was. And then I came back to the United States, and I went to Jefferson in Philadelphia, which has a long history in the field of medicine. I could go into that. But anyway, I did a rotating internship there. And then I went to the University of Miami and had training there, postgraduate. And then I went to the University of California in San Francisco at the Moffitt Hospital that I alluded to, which was their best hospital in that area. So, and then my parents, I was an only child, and they said, Joel, when are you going to come back and actually do something and go into practice? So I had debated about going into academics. I had 2 opportunities, one in Miami and one in University of California. But as the more I learned, I became concerned that there was a lot of politics in being a professor at medical school in the United States. So I came back to practice in Tampa, and I joined a very interesting group of people. There was a fellow by the name of Bill Hopkins. His father had been a sort of a general surgeon here in Tampa, and he had gone to Harvard, graduated medical school in Harvard, and he had a particular interest in cardiology, but he also did general practice as well. And then my hero was a man by the name of Lawrence Kahana, and I had known him from high school, although he went to a different high school. He had been a friend early on, and he was an endocrinologist, and then myself. He married a cousin of mine who became a internist, and later went and worked with the FDA for a while. But what I want to tell you today is a little bit about Lawrence Kahana, because he is one of the most important figures in the history of medicine in Tampa and Tampa in general. Um, and Barat was kind enough to get me his obituary, which of course is very limited and not exactly true to the facts in a sense. One of the interesting things about Larry was that he went to the University of Florida. He was a year or two ahead of me, and he was an outstanding student. He had straight A's. He was Phi Beta Kappa, and also he was very good in athletics, particularly tennis. Loved tennis, and so we shared office expenses. I mean, we weren't directly related, but we shared office expenses. And once a year, I mean, once a week rather, we would talk mutually about some patients that we had and review the chest x-rays and so forth. But the interesting thing about Kahana is that although he graduated with straight A's, Phi Beta Kappa, good in sports and so forth, he could not get into medical school. And it was a puzzle. And he applied for medical school, got rejected, and this went on for a couple of years. So he ended up going to Harvard and being a fellow with a man that had gotten a Nobel Prize in having to do with the physiology of the ear, and he was working with this gentleman and doing some research in that regard. And his wife, she got accepted right away, and she kept after him, apply again. He applied for medical school about 3 or 4 years over and over. And then he said, no, it's no use. I'm just going to become a physiologist and about the ear and so forth. And so she said, no, I see on the bulletin board that you can get a scholarship, apply, and you could go to the University of Washington in St. Louis. So he said, well, okay, I'll do it. And of course, he got accepted. And he, as I say, he later went to Duke and so forth, became an important figure in Tampa in many ways. He was an excellent endocrinologist. He also did some general medical practice, but not a lot. And he saved my life in that one morning I woke up and my blood pressure happened to be over 300, about 320. And I felt very, I didn't feel well. I became a little disoriented and so forth. And I got in touch with him and went to the office, and he said, Joel, he said, I think you have a pheochromocytoma, which is an endocrine infection of the adrenal gland. And, putting out the adrenaline that sent blood pressures up there. That diagnosis only occurs in 1% or less of patients that have hypertension in the United States. So it's quite rare. And the average physician, the average surgeon has not seen a patient with a pheochromocytoma. They of course read about it. So he said, you've got pheochromocytoma. Now we have to find a surgeon that can get that out as soon as possible. And he said, the average surgeon, I don't think anyone in Tampa had ever seen, from a surgical standpoint, ever removed the adrenal gland for that. Because you have to be very careful in removal, and that's another story. So I said, well, I have a friend of mine that is a pediatric research physician in NYU. He knows a lot of people. Maybe I could call up there. So he said, yeah, that's a good idea. So we called up, and I told Raphael, about the situation. And I said, do you know anybody up in New York City that has had experience in this area? And he says, yes, I think so. He says, there's a physician right down the hall from me. I think he's written a book about pheochromocytoma. So he went and got him. And it was a man that had been the physician of one of the Mayo brothers, of Charles Mayo at one time. And then he became more specialized and went into research in New York City. And so he said, Joel, he said, the best one is in Mayo Clinic. He's done, not only has he seen one case, he's done over 200 surgeries on pheochromocytoma. There's nobody else in the world that's done that much. So that's how I got it out. I went up to Mayo's and got my pheochromocytoma removed and blood pressures returned to normal. But that was also an interesting experience, which I could talk about another time, about my experience with Mayo Clinic. So anyway, when I first came back to Tampa, I was amazed. My office was right across. It's an office building right across from, as you get across to Davis Island, right across from Tampa General. And I found out just by chance that no Black person could be admitted to Tampa General under any circumstances, even if they had just been involved in a automobile accident. They were not allowed in Tampa General. And I just couldn't believe that was the case. And so I found out a little bit more about the history. And there was a woman by the name of Clara Fry, who actually came to live in Tampa. And she saw that situation. And she had at first a 3-bedroom home. And she turned it into a mini hospital where she could take Black patients. And so then later it became, she developed the Clara Fry Hospital. And I had a few Black patients, not many. And it was kind of a dormitory style place on the Hillsborough River, just cots, a series of cots, a place for the men and place for the women. And I had just had a few patients there, but I was amazed that was a situation in my hometown for several years. And then gradually, of course, Black patients and all patients were admitted, regardless of their skin color, to Tampa General and St. Joseph's and so forth. So that's a little bit of the background. I just mentioned a little bit before that, there was a charity clinic in Tampa that my friend Larry Kahana told me about. And so I donated some time once a week to go to the charity clinic. But when Medicare came in, you were not allowed to use the word charity, which was kind of interesting. So there was no longer a charity clinic. It became a clinic at Tampa General. But at any rate, what happened with Larry Kahana is, as I said, he was a good tennis player, and he had a friend that was an attorney here in town, a young attorney who developed some, I don't know exactly what it was, but he was in renal failure, he had kidney failure. And so dialysis was just beginning in the United States. There were 3 places in the United States that were doing dialysis, and one was in Washington, D.C. So he abandoned his legal practice, gave that up, and went to Washington, D.C. But there were so many applicants for that that he did not get accepted in the dialysis program there. And he came back to Tampa and told Larry about it, and he died. And so Larry got very interested. Larry Kahana got very interested in the subject, even though he was an endocrinologist. And so he said, well, we've got to start doing dialysis in Tampa. And So he got a friend of his that was from New York City that had quite an experience in dialysis, and had him come down and spend a week in Tampa teaching Larry and a couple of other doctors that were interested how to do dialysis. It was interesting that at St. Joseph's, one of the surgeons there did most of his practice at St. Joseph's. And so he was looking around, and I happened to open a closet, and there was dialysis equipment in there that they had gotten. Someone had donated the dialysis equipment. They didn't know what to do with it. And so they just put everything in the closet. It was kind of amazing how things happen out of chance. So that's how dialysis began in Tampa. It's kind of been neglected as far as emphasis in the history of medicine in Tampa, but I think it's an important one. And then, of course, what happened is that they were beginning to do transplants. And so Larry got in touch with a fellow by the name of Dennis Shires, who had been at the University of Florida. And that's an interesting story. But anyway, he really was responsible for getting the program of not only dialysis started in Tampa, but also recognizing also the need for immunology and transplant. They got a transplant center started in Tampa, and he was really the primary one that was responsible for. As a matter of fact, on Bayshore, on South Bayshore, there is a 3-story building that houses the transplant group and the immunologists there. Well, it was Kahana that got that building built. So he has had quite a background that's been neglected in this subject. And his obituary, of course, it doesn't give that. It's not able to give that history at all. Now I'm going to go back a little bit and tell an interesting story. I'm jumping around a little bit, but something interesting that'll interest Bharat. I went to Tampa General and St. Joseph's. They were the two main hospitals, Tampa General being the main one. But I would go to both places, as he did as well. And at St. Joseph's, there was the old St. Joseph's Hospital, not the one that exists currently, but that was off of Palm Avenue. And it was a very, very small hospital. The emergency room was almost non-existent. It was one big room, and then there were two rooms that you could examine a patient in. And the man that was in charge of the emergency room at St. Joseph's, the old St. Joseph's, really was not adequate for that job. And so I admitted some patients there, and I had a patient that began to hemorrhage from a gastric ulcer. And I said, well, he needs to be transfused. And I was informed that St. Joseph's had no blood bank. They had no access. That the blood had to be that for this man to transfuse him had to come from Tampa General. And so the problem was it was Gasparilla, and the ambulance that was carrying the blood transfusion, of course, got very delayed. And so I just canceled everything else and stayed at this man's bedside until finally the blood transfusion arrived after about a 3-hour delay, and we were able to save his life. But there was a question about EKGs at St. Joseph's that was quite interesting. I'll tell you about. This was in the early days, and so there was an internist that his nickname was Nat, and he lived on Davis Island, had an office on Davis Island, and he became very friendly. He and Dr. Bowling, who was an orthopedic general surgeon, they had really a lot of close ties with a sister that ran the old St. Joseph's Hospital. And so if you wanted to get a patient admitted, sister always gave preference, no matter what the situation was, to whoever Nat picked had a patient, or Dr. Bowling. They had the priority, and so Nat had a basic interest in cardiology, and so in those days anyone could order an EKG and do an EKG on patients, and a lot of general practitioners were doing EKGs, and they really weren't adequate for it, but they would do EKGs and they would make an interpretation and so forth. And so Nat told me and some other internists, he said, well, you have to go back and look at these EKGs. They're old, but they have to be signed by someone that has a background in internal medicine. So I rotated. It was my time, and I went to sign some of the EKGs, and I said, wow, this wasn't correctly interpreted at all, and this was an error here, an error there. So finally I called Nat and I said, wait a minute, although these exams were done months ago, and it's a review and the patients have been home already, some of these EKGs were not correctly interpreted. So he said, Joel, just sign it well, that's all. They're just going to be put in a closet. So that's my early experience with EKGs at St. Joseph's. And anyway, how am I doing time-wise, Bharat? Anyway, well, I don't want to take up all of Bharat's time. I'll tell you an interesting comment about nutrition. There is more misinformation on the science of nutrition than any other aspect of medicine. It's just amazing. And now that I can't read as much and so forth, I watch too much political TVs, and I see some of the ads, and they're absolutely outrageous. But it gets back to how I learned about nutrition, particularly. I had a young woman who's about 20 years old, and she had Crohn's disease, and it was so severe. What happens in Crohn's disease, in the small intestine, you have scarring that occurs, and eventually the small intestine gets scarred so much that it can't pass fluid and do digestive process and so forth. And so she was at that stage where she couldn't really absorb anything from food. And all that we had in those days was 5% dextrose or 10% IVs, which was practically nothing. But that's all we had. And so I began to admit her to St. Joseph's about once every 2 weeks, 10 days to 2 weeks, to get an IV of 5% glucose, which was obviously inadequate, but it gave her a little something. And then one day in a free magazine on medicine that I got, I saw a lead article that there was a doctor in Washington State who had, quote unquote, had developed an artificial gut. And basically what it was simply that he, in the jugular vein, which is a very large vessel, doesn't sclerose like the little vessels in the arm and so forth. And he put in a very large tube and could give patients very, very large solutions of nutrition. It was open that you could keep them going in that way. And so I said, gee, this is wonderful. And I called him up and I explained the problem. I had this young woman that was only 20 years old in the situation, and she was going to die. And so he said, Joel, he said, send her out right now. He says, I'll take care of it, and I'll teach her. We'll get the jugular vein tube in and so forth. So I said, great. So I told her about it, and she said, yes, she'd certainly go. And her neighbor went with her. And she spent 3 months in the hospital then. And in those days, people spent a lot of time in the hospital, not like today. And she came back. And so I really learned about nutrition because everything had to be, how much this, how much that. She couldn't eat anything, even if it was a liquid, she couldn't absorb anything. And so that's really the way I learned a lot about nutrition in many, many different ways that I won't go into. This went on for a number of years. She gained weight. When I saw her, she only weighed, my goodness, about 55 pounds or something like that, and she developed normal weight and so forth. And she took up horseback riding, and it was great. And it was just wonderful. And she was happy, and I was happy. One of the main things of concern in those days is infection. You don't want the tube to get infected because it comes, passes the skin. And the nurses in Tampa at that time weren't that knowledgeable about preventing infection in IVs. But she knew exactly the things that needed to be done to prevent getting infection. And then after 5 years, she died. And I found out what happened. How did she die? Well, she opened the tube on the IV fluids that she was getting through the jugular vein that were keeping her alive for 5 years. And she found out that her husband was going with another woman. And she committed suicide by opening the tube and just letting everything go in until she developed pulmonary edema and died. So that's some of my early experience in medicine in Tampa, just a few ideas. And I don't want to take up all of Bharat's time. Bharat, how are you doing? How am I doing as far as time-wise? Can you hear me?
Let me unmute. Whenever you want to stop, you can stop, and I can continue with where we left off.
Well, I don't want to take up all your time. I have a lot more I could say, because, but I'll.
It depends upon, say what people's feelings are, type of thing. I think.
Right, I'll do one last thing, because my field was gastroenterology, although I was informed about in general internal medicine as a specialty. And I'm going to tell you about peptic ulcer disease, the history of peptic ulcer disease in Tampa. It was a common disorder, and patients with peptic ulcer disease, what happened is a general practitioner from Chicago felt that in his peptic ulcer patients, that if he gave them milk, a diet with milk, and also and acids, that they did very well with the peptic ulcer disease. And so lo and behold, all the patients in the United States began to get, for treatment for their peptic ulcer disease, they began to get a bland diet, and they had to take milk and Maalox and so forth. Well, that was fine for most people, but a lot of Black people have a lactose intolerance, as some other people do. And so I would get some Black patients that told me, gee, I get very nauseated and so forth when I take the milk and the Maalox and so forth and so forth. So I found an article in Lancet. I used to read back when I could read. I used to, every Thursdays, I would read 4 medical journals every week. And I particularly liked the British ones, the British Medical Journal and Lancet. And so a man by the name of Dahl, Dr. Dahl, he went on to do some wonderful work. He was basically an anesthesiologist, but he did some wonderful work in, I think, in pulmonary disorders and so forth. But he did a control study, and he found that the bland diet and the milk really didn't make that much difference. The peptic ulcer, the peptic ulcers would heal, and then they would come back after a period of time. And so he took patients off of the bland diet and milk. And I read this article and I said, gee, this is quite interesting. So that's what I did. I began to tell patients that they could take, they could stop the milk if they wished, and the bland diet, and just have a regular diet. And so it gets into the whole principle of knowing the natural history of disease, which is a very interesting topic. And maybe next week, I'll talk about the natural history of disease, which is a very important concept that took a long time to get people to recognize. And finally, everyone began to accept that you didn't have to have the milk and Maalox, although that still continued. It's very, very, very much liked as a placebo, I guess you could say that. So and there's more history. Just Dr. Kishner, who was head of the department at the University of Chicago in gastroenterology, and he of course had done a lot of reading and came to the conclusion, and he took his patients off of the bland diet and the milk, and recognized that in the natural history of peptic ulcer disease, no matter what you do practically in those days, it heals and it comes back. And so he went into the clinic, and where they had all the, in a folder, they had all the bland diets that the doctors practicing there seeing patients. They could just take a bland diet out, and that's what all the peptic ulcer disease patients got. So what he did one night is he went in and took out all those special bland diets and just put in regular diets. And they continued to use those, thinking that they were the bland diet. And after about 3 months, he says, how's it going? How's your diet? It's doing with all your, oh yes, we use the bland diet and so on. And then he told him, well, I substituted a while back. The bland diet is really not the answer to peptic ulcer disease. And then later we learned from a young man in Australia that more about the history of peptic ulcer disease, that there's a bacteria that has a lot to do with peptic ulcer disease. And that's an interesting history. But anyway, that's kind of a brief history about the natural history of peptic ulcer disease in Tampa. It took a long while for me to convince other people that were practicing that they didn't need to use a bland diet. So I think I'll let Bharat take over, and then next week I have a lot more to talk about what happened in Tampa when, of course, the big change in Tampa was the development of technology, and that's when I saw that things really began to change. But maybe next week I'll talk about that and its influence. So Bharat, take over. May I ask?
I want to add something.
Are there any questions to what I
Bharat,
just?
can I add something that I think Joel knows the facts about? I read, I think, in the newspaper that the physician who started dialysis at TGH and
Yes.
at first, that TGH treated people, but they did not treat without pay. So he had a patient who couldn't pay, and what he did was unlock the department at night and start her dialysis. And apparently once it started, it can't be stopped.
Wow, I did not know that. Thank you.
I think it's in one of the things about Lawrence Kahani, because he snuck people in at the bedtime. So I was going to add that. I'm aware of that also, John. Thank you.
It's so wonderful. And hearing your history, Joel, is just wonderful.
Okay.
Thank you.
All right. So, okay. So, all right. So I think we will go ahead, and I think as we mentioned that we probably started, this is really one of the 10 big advances. I hope everybody can hear me and see my slides. Yes,
I mean, we can see them fine. They're fine.
Okay, good. Yeah, all right, good. So this was like the top 10 of medical advances that we talked about. Is that this is the one that really changed the paradigm shift. Like the accidental discovery of penicillin. It's like the story was that Alexander Fleming was sloppy and he left the petri dish outside, and somebody was doing research in the lower level, and London was hot, so the fungus flew over and settled the mold and settled on the thing, the petri dish. And next day I said, gee whiz, what is this? This is funny. The bacteria did not grow, and that was the start of penicillin. And then more enterprising researchers, from Australia and other people who isolated and they looked at his paper, and the paper stayed in the dark for about 10 years. So it took, again, as to how the medicine starts with stops and jerks and starts. And so that's how penicillin got started. And during the war, it was almost more expensive than gold. People were correcting penicillin extract from urine and administering it. And so the first treatment was done during the Second World War. And finally, so they started to search for this particular mode all over the world, including the United States. And the luxurious growth of penicillin mode was over cantaloupe somewhere in Peoria, Illinois. And then one of the engineers a woman engineer at MIT started the mass production of penicillin. Now, obviously, with any advances comes a warning and backfire. So Alexander Fleming, in his own wisdom, had suggested that be careful, resistance can develop very quickly. But again, the medical community started handing out like candy. And sure enough, we are dealing with the biggest epidemic of antibiotic resistance that we have seen. So I'll have a lot more to talk about on that, So, and then jumping on, I have gone in a sequence arrange. This was the start of cardiology, like OLLI has a lot more women. So Helen Taussig, who was the giant in pediatric cardiology, deserves a nod. And she devised a treatment for blue babies by creating a shunt, between the so-called red channel and the blue channel. So I talked a little bit about it, but I'll just go through that quickly. And she created a shunt under the auspices of at Hopkins called Dr. Blaylock. And he was ably assisted by his African-American assistant named Vivian Thomas. And again, Vivian Thomas had to enter through the back door at Hopkins because Baltimore was below the Mason-Dixon line. And he was an amazing assistant, better than a fully trained third-year or fourth-year resident. And so then they devised varieties of operations at Johns Hopkins. So that was, one can say, this was the early start of cardiac surgery. And again, on the other front, wars are great for medical treatment. And people had direct one to the heart and bullet injuries. So one of the surgeons, I'm sorry, the name escapes me, but he did the experiments because heart could only be stopped for 4 minutes. This was before heart-lung machine. So that was the start of cardiac surgery. So they actually had the race against the clock. And his first 12 patients died, but they were all dogs. So that went around all right. And they were able to successfully save people who had direct bullet injury into the heart, so to speak. So that was, and at the same time, Dr. Gibbons and other people were developing heart-lung machines on their own, and from Philadelphia and Mayo's. And that was one can say that was the start of cardiac surgery. And again, so that, that's the history. And there is a movie made for Vivian Thomas's life. Okay. At the same time, when it comes to babies, one of the anesthetists or anesthesiologists named Virginia Epgar, had devised a score. Simple clinical observation went to a long way in assessing premature babies. And, after so many decades, we still use the Epgar score, which is, a point score based on whether the color of the baby and the breath ability. So that is still used. And again, that changed the treatment of premature infants. While at the same time, while we made dramatic advances, perhaps, as it happens in medicine, we are pushing the envelope. Like from 30 weeks, we went down to 20 weeks, 25 weeks survival, to as little as 22 weeks. And these babies are really tiny and their lungs are not developed. They get sometimes used to get oxygen toxicity. They have multiple birth defects, including heart, and require surgeries, and it costs millions of dollars. And again, it happens, hospitals play the game. They may have a pediatrician and a woman gives birth to hospital X, but they don't have a neonatologist on the staff. So they are freely contracted. So neonatologist bill can be in $10,000 to $20,000. So that's the tragedy of our healthcare system. that, a woman who gives a birth does not expect she's going to a neonatologist, so she should go to hospital Y, which has both facilities. So, and again, this again raises a very ethical question. Just last week, there was an essay from a mother about a child that was born premature and had a lot of genetic abnormalities and had already undergone multiple surgeries. And she writes a very moving essay. And she's not a physician, but she's a ethicist and a journalist, so to speak. And she wrote about no clinician mentioned the word hospice for babies. How much we are putting these babies, we can say, well, these babies feel pain, and are we pushing the envelope further? So it was like, so there was an essay that was in the New England Journal. Unfortunately, that's behind paywall, but I can try to send a copy of it, so it raises varieties of questions, unfortunately, I think Attorney Weaver is not in, but otherwise we'd love to see his comments, And I think Ron Hammerly, who's a bioethicist in OLLI, so it would be interesting to see what his intake on it. This is the first time I've seen an essay. And I was a default pediatric echocardiologist, in Green Bay. And there is an abnormality where babies do not have developed left heart. And that was almost fatal. So, and that is the only time the neonatologist would say, we're going to let the baby die because there was no surgery around. But now, even then, there is a surgery available even for that. So the technology has improved dramatically and there was an article in the Canadian Journal that they were able to keep a baby, two twins. They were 22 weeks and 330 grams, and they both survived after 8 months of hospitalization. But the parents were actively involved in looking after these children because it requires, once you take them home, you have to be a full-time nurse. So that's enough about it. And I think Joel inspired me to make a slide about Clara Fry. So I think next time you run Riverwalk, you can see her plaque. And and she did, variety of things. And there's a pavilion named at Tampa General in her name now, and a physician named Dr. Mac Wilton, a local surgeon, worked with her. And unfortunately, the hospital was demolished and closed in '73, either due to overcrowding, lack of funds, and what have you. And she died in 1936. So that is a brief interest of my forays into local history of Tampa. Okay, so we'll take it. And at the same time, some of you, I think quite a few, in fact, took my class on genetics, and this is how medicine can backfire. That after Darwinian evolution theory, his cousin named Galton had formed the idea of eugenics on the back of Industrial Revolution, and they wanted all the upper class to breed. They were having less children, and Galton contributed, a lot to statistics as well. But he started the movement of eugenics. And if Europe does one thing, America does it better. So we jumped into it on this side of the Atlantic with both feet at the Cold Spring Harbor lab in New York. A guy named Goddard, who was a psychologist by training, started, the eugenics movement. And it was very popular, by the way. A lot of who is who in political field and were in favor. And this again followed on the tails of the immigration from Southern Europe. They were the so-called undesirable, and the Latins who were coming in, and the Russian immigrants were pouring in also after the Russian Revolution. So they just played right into their hands, and eugenic movements was big, and people were the well baby contest. So, and Siddharth Mukherjee has written a book on gene. But at the same time, they really went to the extent that sterilizing the people who were mentally retarded, or, just based on appearance. There was no real clear-cut psychological test. And this was the infamous Darwin tree. So genetics has always had the skeletons in the closet, which we talked about at length. And Siddharth Mukherjee has done the book about it. And this is well known to people who have taken my classes. All right, moving right along. There are good things on preventive aspects that were taking place. And a Greek physician named Georgios Papanicolaou, on his own, was doing vaginal examination, and based on histology and appearance under the slides, was able to diagnose pre-malignant cells. But it took, again, medicine is very conservative. When it took a number of years for his technique of Pap smear to become approved. And it reduced the incidence of cervical cancer dramatically. Okay. And this is, and now we obviously learned that the virus is responsible for it. And the virologists showed the association between human papilloma virus with cervical cancer. And that is one of the strongest association that is known. Because remember, we addressed a little bit about how we got on the wrong scent about looking for virus as a cause of cancer. But this was one of the strongest association which we found. And now obviously we have the vaccine available for that. And again, the Pap smear has become preventive aspect. So that has to be one of the big home run that medicine has come up with. So the HPV, there is a more direct test available than looking at the slides and trying to make sense out of it. And so this is, and again, this was followed with the preventive aspect increased with availability of health insurance, which started, in somewhere in Dallas, and we'll talk more about it, about the wellness care and the value of physical examination. I think we still have a few more minutes, so I shall move along. And at 11 o'clock, we'll take a few minutes break. All right. So, and then again, at the same time, on the tail of penicillin, there was the golden era of antibiotics, one can say from 50s to, because people went all over the world looking for various fungus and molds which would kill bacteria, the evolutionary bacteria and fungi, so that evolutionary arms race and the viruses, all the various kingdoms have been fighting war way before we came onto this earth, so to speak. So we started taking advantage of it. And in the soil, somewhere around New Jersey, I may be wrong on that, a mold was discovered called actinomyces. And after screening thousands of it, Dr. Waxman was able to, because tuberculosis bacteria is very hard to grow. It takes almost 6 weeks for culture to be positive. It's why it's called fastidious organism. So this was discovered in the farmland of New Jersey. And a lot of the work was done by his graduate student named Albert Schatz. But again, and this was, and unlike what happens in present day, Dr. Waxman did not give any credit to Albert Schatz, and he just went through some legal trial and he got some of his thing, but rightly he was almost cheated out of share of his Nobel Prize, So Waxman, and so this was okay. And Waxman was not a physician; he was a PhD, and a lot of the work on tuberculosis was done by Mayo Clinic MDs. So we made, tuberculosis was one of the chronic illnesses. We read about in the literature the so-called languishing death of pale-looking women who are at sanatorium, and taking 6 months. A lot of the classical poets died of tuberculosis. But the reality is much more harsh than that. Tuberculosis was overcrowded, in the industrial era was this thing. And as a medical student in India, I've seen my share of open tuberculosis. And knock on the wood, my BCG skin test was still negative. And that was the earliest days of vaccine called Bacillus calamite-guerin vaccine that was available for tuberculosis. All right, let's see if somebody has a question in. Oh yeah, yeah, absolutely. Churchill, Teddy Roosevelt, George Bernard Shaw, they were all big eugenic. In fact, Churchill had proposed a law type of thing we talked about, but fortunately the law was not passed about compulsory mandatory sterilization in, that thing. So that, yeah, it's a very checkered past of genetics. So they always have this, a little bit of a guilt, that thing in there. And okay, and again, now as it happens, the resistance raises its ugly head. The cost of tuberculosis is 67,000, at least in the Western world. But, and, in other developing countries, it's far less cheap. And, but again, the compliance is a big issue because tuberculosis treatment, at least when I was in school, required about almost 2 years, and people after a while give up, leaving rise to resistant bacteria and spreading into the community. Now there are trials of shorter therapy, which seem to be more productive. But at the same time, the so-called multi-drug resistant tuberculosis treatment is frightfully expensive. And we have alluded about, Paul Farmer, when in the former Soviet Union, extreme drug resistant tuberculosis was a big problem. And he made through WHO and pharmaceuticals, he made some serious attempts at combating this problem. So I think okay, my clock is 10:56, so I'll still go through a couple of more slides, Okay, and again, the life antibiotic resistance is a big issue, as we talked about. I did a class. I think some of you attended that. I'm not sure as to where. I think it was. Okay, this was in 2016. We did a class, and these are the slides from our CDC type of thing. It's a growing problem worldwide, and as much as our expat Brits would like to knock NHS has done a remarkable job in reducing the overuse of antibiotics. They have actually taken it, and they have been very successful in reducing this. And sometimes the medical establishment does not, we are all trained to do something. So whenever a patient comes with some type of a sore throat, and even though we, in our gut, we know that this may be a viral infection, it's easier to take a path of resistance and give out a prescription for Z-Pak, which is a broad spectrum antibiotic. And in the third world, it can get the antibiotic prescription even without, over the counter. So, and again, the farm use of antibiotics has exploded, in spite of, in chickens and poultry and animals. So antibiotic resistance, and not just physicians, but the farmers and the big agro industry is a big culprit. And there's a lot of antibiotic that goes into the water. The companies that manufacture are not very careful. So again, we are creating a monster. And when Obama was president, and there was a big initiative to make some attempts at it, but with COVID, I think that has gone on the backside. And to just go to your numbers that are sobering, 2.8 million infections occurred due to antibiotic resistance in the United States, with 35,000 deaths. And if you are in hospital getting antibiotics, you develop a nasty bug called C. difficile, which causes massive diarrhea, and you could be really deathly sick. So if we add the deaths that would occur from C. difficile, then the number of deaths jumps up to about 48,000. And obviously, some of you may be aware that the treatment of choice for that has been fecal implant, as much as gross it may sound. But that is not the only bug, but there are other bacteria that, and the recent movie Zombie comes to mind, that there is a type of candida, which is a simple thrush infection, that is developing resistance to a lot of the antifungals that are available. So we have some bigger issues to deal with, and hopefully one of these days, all the major powers will get around. So I think we're coming up to 11. I shall stop my monologue, and I will pause the recording and get back in about 5 or 7 minutes.
But in San Francisco and California, it's another Moffat.
Yeah.
Okay.
Yeah.
All
Joel
right.
and I
I
have
think we
had
should-
lots of good discussions about this. Yeah.
All right, I think we should get started because we have a lot of material to cover. So I think
Yeah.
we shall get on with this thing. So again, so the idea about treatment without antibiotic is almost, hard to imagine type thing. So that is going to be a big problem. And similar to Joel, when I was 8 years old, I received the first US-based medicine called chloromycetin but clinically that thought I had typhoid, I'm not sure how that was, but that was, now at that time, we were not even aware, people, that chloromycetin can cause aplastic anemia, severe bone marrow depression. Okay, and it's amazing how the word became united type thing, because the chloromycetin comes from Streptomycin Venezuela, so it was discovered in the soil. So you can just see a bacteria, a fungus that was picked up from Venezuela. Medicine was developed by Park Davis, which is no longer in existence, and was used in the so-called third world or developing countries to save a kid's life, Okay, so, but again, we're not aware of, the side effects that would occur. So, but now it is no longer marketed at all. So that's, and this is the film that I was talking about. Hopefully this will play. This was probably one of the few videos I shall show. I think some of you may have seen it. If so, I apologize.
Is that there are 9 bands, and at the base of each of these bands, we put a normal petri dish thick agar with different amounts of antibiotic. On the outside, there's no antibiotic. Just in from that, there's barely more than the E. coli can survive. Inside of that, there's 10 times as much, 100 times, and then finally the middle band has 1,000 times as much antibiotic. And then across the top of it, pour some thin agar that bacteria can move around in. The background is black because there's ink in it, and the bacteria appear as white. First, you see they spread in the area where there's no antibiotic, up until the point they can no longer survive. Then a mutant appears on the right. It's resistant to the antibiotic, it spreads, until it starts to compete with other mutants around it. When these mutants hit the next boundary, they too have to pause and develop new mutations to make it into 10 times as much antibiotic. And then you see the different mutants repeat this at 100. And after about 11 days, they finally make it into 1,000 times as much antibiotic as the wild type can survive. And so we can see by this process of accumulating successive mutations that bacteria, which are normally sensitive to an antibiotic, can evolve resistance to extremely high concentrations in a short period of time.
Okay, so that's from some little school up north. Okay, and so this is again the more cartoony slides. We already talked about it, but so we won't be. And even the good old gonorrhea is going to be resistant to antibiotics. So in the UK, there have been some cases of gonorrhea that's resistant. So the treatment may end up to be sitting in a mercurial chamber and swelling. So, and so this is, again, so we have spent enough time on antibiotic resistance. Now, at the same time, Kevin talked about, the start of anesthesia, which started, back in the, not even in the 20th century, but in the 19th century. The treatment was actually, during the early days of chemistry, Sir Humphrey Davy, they were all having fun with nitrous oxide and saying, oh, we feel less pain. But nobody thought about it using for an anesthesia. So they took the chemical nitrous oxide stayed dormant for several years, and finally another chemicals called chloroform and ether were developed, and this was used by a dentist in Georgia, but he did not publish the results earlier, and then finally it was used for removing a tumor in the neck at the great Mass General Hospital. And at that time, the surgeons obviously did not wear a glove, and their famous statement was, "Gentlemen, this is no humbug." So that was the start of anesthesia, and Queen Victoria was one of the earlier royalty persons to receive chloroform anesthesia. So that revolutionized modern surgery, and that was again taken up in a more systematic form by the great Dr. Halsted at Hopkins. And so finally, pain of relief. That was, and again, we may have mentioned about this story about the war and the professor and the madman that we have talked about, which was how post-traumatic trauma can affect even the medical personnel who work, and we are seeing that in a dramatic extent. Just the other day, there was an article about how many physicians have dropped out in 2021, along with nurses at burnout. On the other front, with the nitrogen mustard gas, people saw that there was effect on the blood count during Second World War. And that was, those of you who have a medical background will remember the two famous physiologists, Goodman and Gilman, classical textbook of pharmacology. So that was the start of chemotherapy for advanced lymphosarcoma. Sarcomas are basically cancer, but they grow faster. So this was the start of nitrogen mustard in low doses, and the tumor was regressing. Again, this was like the baby steps of chemotherapy. And so this further multiplied, and was the next slide will elaborate a little bit more. So benefits of wars are great. World War I was the start of plastic surgery for skin grafts and burns. World War II, chemotherapy, Korea, MASH units, and during the Iraq War and Vietnam, obviously the helicopter evacuate and the triage. And so the wars have been dramatically beneficial, and obviously Tampa USF has a big surgical training center for people who are going to be working in Iraq type of thing. So if we ever get a chance, we should probably visit that, type of thing. So they do go out some tours to operate in very difficult conditions, so to speak. So these are some of the advances that have taken place. This is a lot more, so people may recognize probably those from the East Coast. This is the famous Dr. Sidney Farber, who was a pathologist, and he undertook a treatment of childhood leukemia. And it took, it was what a dramatic effort for starting doing chemotherapy, and obviously there were a lot of death, a lot of morbidity and mortality. The kids got sick, and people thought this man was crazy, and he was given an isolated wing, but nobody wanted to be part of it, and the residents were stressed out. And then again, his mental was carried out by people in the South. I think it was in Nashville, Tennessee, and people at St. Jude. And this was again the big point, how science can be politicized. The rich heiress, Lasker family, funded, and there was the, St. Jude's protocol, and and the March of Dimes protocol that followed from polio, and that got involved into chemotherapy. They started raising a lot of funds, and with government got involved, and that was the start of the chemotherapy. Start, and again, very steroid chemotherapy agents were used in an incremental basis. And the people down south had used as many as 7 drugs for treating. So you can just say this was one of the big top 10 advances for curing childhood leukemia, if you recall from my first slide. Okay, and on the heart front, something that I know a little bit more about was that how in science we sometimes learn things accidentally. And the heart, originally a cardiologist named Dr. Soames was doing a test to measure pressures inside the heart at the famous Cleveland Clinic. And accidentally, the catheter, which is the hollow tube, fell inside the coronary artery, and a radioactive contrast material got injected. Because before that, it was considered that if you inject anything inside tiny arteries, heart would stop and patient would die. And sure enough, the heart slowed down. And it is historically said Mason Son was a crusty old cardiologist, almost a frustrated surgeon. A cough, USOB, and the patient coughed, and the rhythm started again. So that was the start of what is called selective coronary angiography. So that was the treatment of blockages which occurred due to cholesterol plaque. And again, remember the time frame. This was the heydays of smoking. The World War II soldiers were given a packet were sent Coke and cigarettes so that they wouldn't get homesick. So that was the right time to diagnose. So there was the coronary arteriography was the start of heart surgery as we know it, type of thing. And again, the varieties of treatment trials were done. And again, even as early as when I started in 70, treatment of heart attack was very primitive. We gave them morphine, oxygen, and put them on bed rest. Okay, so that was the, and maybe if we're lucky, we gave them blood thinners. Okay, so I already talked about the paradigm shift as to how in medicine, even though we knew about streptokinase, we relied on the pathologist and did not offer treatment for clot dissolving for almost 30 to 40 years until the Germans took up the back again and tried to dissolve the blood clot, revolutionizing. And I remember there were jaws where mouths were open when they reported in the early 80s at the College of Cardiology that it was, they injected the clot dissolving enzyme inside the heart and opened up the artery. So that was like a dramatic paradigm shift that one can see, type of thing. So, and again, and now the neurologist, and then again, Genentech came out with another clot busting drug, which is called fancy word called TPA, called tissue plasminogen activator. Plasminogen is a type of protein that dissolves the blood clot, and it's more genetically more pure drug, so you do not get the allergic reaction that one gets from streptokinase. And again, and again, the Genentech, as it happens with the new biological, the cost was $2,500. And when I told one of the nurses, this drug is $2,500, and my hands are shaking. Don't tell me that. So that was the early thing, And now obviously $2,500, for 5cc vial seems like a bargain nowadays when you look at the newer drugs. So I shall have a lot more to talk about the cost of drugs as we move right along. Okay, but that's just the forays in cardiology. And at the same time, on the other side, Dr. Blake, who is a chemist at the Imperial Chemical Industries, he was developing treatment because Joel talked about adrenaline earlier, the hormone that comes from adrenal. Ad means on top, and renal means kidney. So a little gland that says this is what he was suffering from, pheochromocytoma. So blocking that adrenaline was various chemicals that were devised by Dr. Blake, and that was called beta blockers. So again, this was 50s to 70s was the heydays of pharmacological. Variety of drugs came into existence, and just for good measures, Dr. Blake not only developed beta blockers, which was again a big paradigm shift for treatment of blood pressure. He also developed H2 or H2 receptor blocker and developed a drug called cimetidine. That revolutionized the treatment of peptic ulcer disease. I mean, the diet that Joel was talking about was called SIPPY diet, SIPPY diet. Okay, and that was like milk and bland diet, which people hated with passion. But the H2 blockers, which was actually neutralize the stomach acid, and that's why. And I'll have a lot more to talk about the so-called purple pill and the campaigns. On the other front, we had treatment for diabetes called sulfonylurea, and the most common drug, which is nowadays used, called metformin, which is used for the cornerstone of diabetic treatment. Some of you may even be on it. But there was a cousin of it called fenformin, and that sounds similar, but no, was not the same. It caused a nasty side effect called lactic acidosis, and that was nothing to sneeze at. People actually died from it. The blood, your pH in the body dropped dramatically, type of thing. So the varieties of medications became available, and we learned the association of salt and blood pressure type of thing. And again, the race comes into the picture. There was a hypothesis called salt hypothesis amongst African Americans, that people who survived the harsh transfers across the Atlantic, were better at conserving the salt because of lack of water and food and thing. So that's why they have more hypertension. So that I think that's just a hypothesis at this stage. So how race and science still plays a role in terms of medical thinking, rightly or wrongly, that that is a very much role. And you can see that again, the big change that we made was treatment of hypertension, again. And we'll have now at the same time, we were talking about overdiagnosis and overtreatment. There's something called the task force for blood pressure. And every 5 or 6 years, all the who is who get together and form guidelines for blood pressure. And the guidelines for blood pressure, they keep lowering the target, And when I said it went down to 130 or 80, I was just cringing. Says, my goodness, we have difficulty in getting up to 140 over 90, and we are lowering the target even further. So all of a sudden, we have added, we have taken, added another 20 million people. We have transferred from healthy to sick. So that's the example as to how medical committees can change things about from healthy to sick. One day you're healthy, next day you're sick. So that's where the overdiagnosis treatment comes into the picture. And I'll have some other examples of it to share with you as we move along. And so this is, and this is the slide that illustrates very carefully. There's a Canadian internist named Dr. Welch, so this is his slide, by the way. And as to how when we say at certain time, we can create, I don't know if I can zoom this on this, perhaps. Yeah, I think I can. So there's, we have no harm to net benefit. So there's a threshold point that we check, in terms of, number of affected persons. So if we increase the pool of people who receive treatment, and the classic example that I should jump ahead was, doing mammography type of thing, that in 2010, with a big, large multi-center study, it was devised that doing pap smear in women without risk factors between 40 and 50 did not make that much difference in mortality for breast cancer. And that was opposed by, because again, it was covered as quote unquote part of health prevention. So that recommendation did not go well. And the varieties of committees, like the Committee of Obstetrics and Gynecology, versus College of Physicians. The criteria are still totally different as to who is right, type of thing. And again, the European countries do things a little bit differently. Okay. Okay, I'm sorry, I made the chat bigger, which I should not have done, because then I can't see my notes. All right, okay, we're back in business here. So that's something we talked about. The overdiagnosis is still was a big problem and is getting bigger, so to speak, type of thing, Okay, and now again, this was 1967, was an Argentinian surgeon who actually wanted to be a heart surgeon and just showed up at Cleveland Clinic. I want to learn heart surgery, and had no training. Started out as a technician and went on to become the pioneering heart surgeon, okay, Dr. Rene Favalaro. And it's a very human interest story about Dr. Favalaro, that he was obviously the superstar of bypass surgery at Cleveland Clinic. He mentored a lot of people, and he was offered varieties of, academic positions, but decided to go back to Argentina. And during the Argentinian Revolution, the government, his funding was not sufficient, and he got distraught and actually, I think, killed himself, type of thing. So, but this was the start of, so very, very inspiring man, like Dr. Rene Favalaro, not only. And so again, so the bypass surgery came into existence. And again, we thought that that the human body was going to be simple. We could put new bypasses and we live happily ever after. And some of you may recall that the bypass is just plugged up because we did not understand the disease pathology, and the role of cholesterol was we are just becoming aware, but we did not have adequate therapy for it. That had to wait until the late 80s when cholesterol lowering drugs, i.e. statins, became available. And that's when we made a dramatic impact in treating the pathophysiology of the disease. And as Joel talked about, the pathophysiology of disease is extremely important. It wasn't just simply fixing pipes, as the surgeons thought that they could do. And again, when we are using a small caliber blood vessel, which is the saphenous vein, which is taken from your leg as a bypass graft, and while the arteries are thick walled and have multiple layers, so that's why the bypass is plugged up, and the results were dismal. And the Veterans Cooperative Study was revealing as to how doing triple vessel bypasses you prolong life, but did not make that difference for one or two. So that was a big controversy that we went through. And now again, we have moved dramatically forward with minimally invasive surgery. And again, some of the surgeons who were poorly trained were resistant to the minimally invasive surgery type of thing. And the power, and as patients, I feel bad that people do not know as to whether the surgeon is trained in this skill. How people pick surgeons, you pay more attention to picking a plumber than picking a surgeon. And because information is very hard to get. Now in the last few years, the data for various hospitals are available at website, but not all hospitals post the data. But the data, but very few people have the patience and the wherewithal to assess the data of morbidity, mortality. And the New York City has done a nice job about doing the data and making it available. So I should have a slide for that later on when we talk about US healthcare and our problems. Okay, moving right along. So now something that is very obvious, we think that it should be true based on common sense, but alas, that turns out not to be the truth. Treating irregular heart rhythm, some of you are aware of it, that skipped heartbeats can cause the heart to fibrillate and quiver like a bag of worm and stop. So we thought, okay, well, prevent the skipped heartbeats, people should do better. So, and makes sense. We had drugs available for it, so we decided giving it out. But there was a study that was done called CAS study. In cardiology, we love the acronyms for cardiac arrhythmia suppression trial. It turned out we actually killed more people than saving their lives, because the electrical circuit, which is on micro voltage inside your heart, is a lot more complicated. A variety of short circuits still develop. We suppress the big ones, and so we're developing short circuit. And this goes down to similar to, I was thinking about it, just like the nuclear physics. We learned the secrets of atom and proton, but underneath that, there were quarks and, and the interactions, So when we finally learned the sodium and potassium channel at the cellular level, then we realized that, yes, we were causing problems by, some of the antiarrhythmic drugs. So what was apparent based on common sense did not pan out. So the CAST and COURAGE trials actually changed the paradigm shift that we stopped giving out antiarrhythmic drugs willy-nilly type of thing. So this was, and the same thing, okay, the advances that took place, which were similar with back in the 80s, balloon angioplasty was discovered by kitchen enthusiastic cardiologist named Dr. Andrea Grunzig. He actually worked in his kitchen to develop plastic catheters to blow up the blockage in the balloon. And again, this was like a paradigm shifting event at College of Cardiology meeting. He did not even have a paper, he just had a poster. And everybody was aggregating at that poster. And Dr. Grunzig, then he further developed technology. And again, Americans did better than Dr. Grunzig. He was Swiss and very conservative. And we started doing angioplasty, and stents have exploded. We are putting in, and again, overuse is the big bugaboo type of thing, that people are chasing pictures and instead of this thing. And various multi-center trials that have been done said, well, unless you have severe symptoms and dramatic changes, treating a lesion that is there does not seem to make difference. So overuse of stent is a huge problem type of thing in cardiology. People, and it's so-called oculostent reflex. You see a blockage, you should chase it. And I had some nasty experiences with our group. We had a associate with us, who was really a very overly enthusiastic about doing procedures, and he went on his own. And it was just, we were just shaking our head. Nurse would call up, Dr. F would like you to have this test. He would do a hard scan test. Oh, I see, it's a little abnormality. He would like to come in for further test. Patient would come in, oh, wow, doctor calls me, he's concerned about it. And he would put another stent, and that generates, another $5,000 of income. And I would have to say that, obviously, I had a reasonably good car, a small Lexus, but he was the only one who had a 12-cylinder Mercedes-Benz in Green Bay. And I wanted to be a parking lot attendant so that I could drive the car. And he drove 3 miles, and the car never went into second gear, I'm sure. So, but that's, I'm reminiscing, but it just shows as to how fee-for-service model backfires for us. Okay, because, we get rewarded for doing procedures. And I had mentioned about, it's like a patient had complained about me because I would not do a stress test, and said, oh, you did, service was not very good. So again, we talked about the trials, and, and again, this was the start of heart valve surgery, by, Dr. Lillihei, who was a giant in terms of cardiac surgery. And again, surreptitiously, how discoveries are done. He had problem with heart slowing down of babies that he was operating on, or a hole in the heart. And he talked to the garage door mechanic next to him, says, well, I have a problem. And this was the early days of transistor. So the man had read the article in Popular Science. He said, well, doc, let me see what I can do. So he came up with a device to simulate the heart rhythm, with a box. Again, there were no human trials at that time. There were, and he used this metronome type device. And that's the start of pacemakers. Okay, he used the piano tuning device, and that was the early days. And that went on to become a company that is well known to some of you called Medtronic. Okay, so that was the start of, Roth Beck and this thing. So some fascinating stories. And I think the reason why I went into cardiology, because we had a lot more gadgets, and, it was exciting at that time, type of thing to work with, because oncology was depressing, obviously. And again, it was a challenging thing because there was, obviously not so subtle discrimination against foreign graduates, so it was a type of thing. Cardiology was considered the prize in internal medicine, okay, if you want to do subspecialty. And so again, this was the start of the Star Edward valve that was done on the West Coast at the University of Oregon. And again, the collaboration of heart surgeon and engineers, Starr and Edwards. And those days, the surgeons and physicians were more altruistic. And Dr. Starr did not ask for patent, but Mr. Edwards was his engineer, and he took out the patent on valves, and that went on to. And the early days of heart valve surgery were difficult because this was the so-called ball and cage valve, and that caused crushing of the red cell, causing anemia type of thing. So, but that the technology has gradually improved. I would digress and say that yes, at the same time, the medical devices approval is very, very lax with the FDA. Okay, and the device that does not have to be tested and were approved for human use. And some of the valves that were put, which were, the name is academic, were developed fracture in the strut, in the metal type of thing. So we had lots of patients who were following, with our fingers crossed that the valve may fracture, causing disastrous sequences. Okay, so so some of the approval of medical devices is far more lax than you would like to be. And as a patient, you have no way of knowing that this device has not been, had undergone even animal testing. It is just similar to the one that was approved. So that's how, the 501(k) law, these are approved, so to speak. And just to digress, there's atrial fibrillation is the irregular heart rhythm that occurs due to a blood clot into the top chamber of the heart called left atrium. And a device that was called lariat device, which is like a suture that is tied on the appendage, which is a little pouch that occurs. And that was only tested for abdominal wound, and that was approved. And it turns out that in aftermarket, a lot of people had perforation of the heart, including some deaths. So finally, the FDA issued a warning. And finally, afterwards, now the company is doing some real, double-blind trials. So the device approval is buyer be aware, so to speak. So we'll talk more about it when we talk about joint replacement. Okay, and now, biggest advances in surgery. And in cancer and increasing lifespan, what happened in 1964? Okay, Surgeon General warning. So we can pat ourselves on the back as physicians and surgeons, but the biggest problem that is made is the advanced testing. And along with that, and you may recognize as to how this was promoted. And I think Joel may remember the ad, Lucky Strike, the cigarettes that doctors smoke. Okay, I mean, I couldn't find that particular thing, but this is good enough as to how our former governor was promoting the cigarettes, I think. So this was, and okay, and at the same time, the data was available from the early 50s from Bradford Hill, the epidemiologist in UK. But again, the lobbyists, so that's what we can talk about an hour about the lobbying, the power of the cigarette industry. Okay. And at the same time, the Bradford epidemiologist has contributed dramatically to reducing diseases. The nurses cooperative study that has gone on for, almost 40, 50 years, and this has made a dramatic difference in assessing various factors that we are all very well aware with the onset of multiple comorbidities, the smoking and, trans fat and obesity, all of these things, and the relationship with not just with heart disease, but with other diseases such as colorectal cancer, pancreatic disease, and type 2 diabetes, of course, so these correlations have been well established, type of thing. And again, we have some steps, one step forward, two steps backward that we've gone through that we'll address in a little while. Okay, and again, the obesity related thing, just about any illnesses you can think about has relationship with obesity, including gallstones and cancers type of thing. Okay, and one of the few success stories that we have seen, this was the cover of Time magazine. Some of you may have seen this slide, new ammunitions. This was the war of cancer that based on leukemia, one of the physicians, a hematologist, had worked on the chemical pathways of cellular metabolism of an amino acid called tyrosine, Tyrosine. It's one of the 20 amino acids essential. So tyrosine kinase inhibitors that he devised a drug, which was, called amitinab. The name is maybe more familiar with, called Gleevec. And that was the biggest hit that Genentech had. It cured about 85% of the childhood leukemia. And that success has still not been repeated for any of the cancers. So, but this, and again, just a word or two about cancer. This is the data that from a UK-US collaboration, why it is so difficult to treat. Because it's not just one disease. There are multiple factors that we deal with. There are not, there is extra, there are tons of mutations that even healthy people have, and there are so varieties of problems that still remain. And there is a nature and nurture collaboration that takes place in the origin of cancer. Microbiota, your gut microbes getting framed, and the tissue, that architecture for metastasis may be different than the primary tumor itself, So, and some tumors are lethal, some are non-lethal, as we talked about earlier about prostate cancer, as to how we are hitting, using a machine gun to kill, a fly, so to speak, sometimes, And I think, and there is no particular standard treatment, as Joel and Kevin know very well, depending upon where you end up with, you can get anywhere from expensive proton therapy for prostate cancer to simple observation type of thing. So, and depending upon, and so I'll have some more slides to say. But again, in spite of all these factors that we talk about, and we've talked about how the evolution of Darwinian evolution plays a role, because Mother Nature has no interest in having you be alive at age 90, because once you have reproduced, that's about the size of it. The cells start degenerating, perhaps. But in spite of that, we have made some cancer incidence has dropped by 33%, whether it is just simply due to reduced cigarette smoking or due to therapy, or perhaps a combination thereof. So, okay. So these are varieties of problems that we're dealing with, because in the old days we were treatment XYZ is for lung cancer, and treatment 1, 2, 3 is for breast. But sometimes a drug that is used for breast cancer can also be useful for lung cancer metastases. So we have, and again, so we are dealing with the moonshot, and hopefully we'll be successful this time, And again, so there were in the 21st century Speedy Drug Approval Act has been passed, and again, the lobbyists have a big role to play. And I have some notes and references in my notes that we will see if you have time. Okay, now let's jump into overdiagnosis. So if some medical care is good, more must be better. But is it? And this is, you saw this slide earlier in a different from a different source. That it shows as to how it certain diseases progress at a length of a turtle. So it does not make sense to hit them with aggressive. Classic example is prostate cancer. Some diseases are very slow to progress, while others, like sarcoma, progress as wildfire. So it's a different approaches take place. So this is where the overdiagnosis occurs, that thing. And at the same time, and the part of it is medical culture. We have fear of missing a diagnosis. And again, we're all perhaps, more used to treat than not treat. So to hold your hands, to sit on your hands is harder type of thing. So that's why we have a lot of overdiagnosis. And I know some people who are trained at Mass General, and the biggest sin at Mass General is to miss the diagnosis. So when you see the protocol of the case reports of Mass General, I mean, that's one example that comes into my mind, type thing. So they were looking at a child who was bleeding from the teeth and had rash on the body type of thing. And, they went through the $1 million workup, including bone marrow examination, various blood tests, various scans, and other stuff. Finally, somebody thought that they would decide to take a good diet history. And the mother was feeding the baby just milk and biscuits. So the kid had vitamin C deficiency. This was a 3-year-old. Nobody bothered to ask the simple history and physical examination. And again, to their credit, would say, yeah, we have an egg on our face, so to speak. We should have asked history. So, but that was, I still remember the case report, I was just shaking my head. Said this happens even at the great Mass General, man's greatest hospital type of thing. So it does happen. And even this is another thing as to how medical errors compound. There's a well-known Canadian physician, who has various blogs and has done varieties of things, named Dr. Peter Attia. And when he was a medical student, obviously he had a renal tumor, and being a VIP, they wanted to give him special care. So they rushed him through the things. And at the great Stanford Hospital, they took out the wrong side of the kidney. So nobody bothered to really mark or decide type of thing. So, and again, and so it was just another thing. At the same time, the surgeon did not come and admit that they had made a mistake, did not even apologize. So, in the blog that Marty McCarthy and Peter Attia talk about as to how, we handle, and sometimes, that may be one of the causes for being sued, as to not to admit when there is a mistake, so to speak, okay, type of thing, and even I remember even in Green Bay, we had this case type thing, so where somebody took out the wrong side of kidney. So in a way, it's better to deal with heart. There's only one heart, so you can't mess it up very easily. So paired organs, watch out. Okay. So this is, these are some of the problems with ChemSid. And similarly, we have changed the guidelines for blood pressure that I talked to. And similarly, I think I missed the slide in the earlier part about the very tight control of diabetes. We thought, okay, well, perfect diabetic control would go a long way in reducing complications. There was something called the Accord trial that was done. Alas, it turned out not to be the case. So, but still, there are physicians who insist on perfect diabetic control. There's a famous diabetic clinic called Jocelyn Clinic South. So there was they recommended this vigorous diabetic control type of thing. So this is, so blood pressure, diabetes, and the same way we'll talk a little bit more about cholesterol as to how we have kept lowering the paradigm shift. The same way, for treatment of screening cancer type of thing. Again, we talked about the PSA, which has not been that sensitive in terms of follow-up, and diagnosis. And so that is considered frowned upon recently for, this thing. It can be useful, but again, screening everybody has not panned out. The same way for mammography, because we were talking about technology. In the early days, mammography was not that sensitive, and we were able to pick up tumors which were 2 centimeters. Now, with the high resolution and 3D mammography, we can pick up tumors that are 0.2 centimeters. So 1/10 of the size. Again, is it worthwhile chasing those tumors? Are we prolonging morbidity and mortality? The jury is out on it yet, type of thing. Okay, so this is, so that's a big shift as to how we have changed type of thing. And again, for prostate, we've gone from doing a rectal examination to PSA to ultrasound to more sophisticated technologies. So again, and there are some physicians who are so-called early adopters to some who are skeptic. So it becomes like a Wild West. So as much as physicians frown upon treatment guidelines, it becomes a big thing as to how standard is approached, and the varieties of surgeons. Another medical writer named Dr. Atul Gawande has written a book about checklists. And at Hopkins, they instituted the checklist for surgery, and that has made a dramatic difference in terms of reducing medical errors. And the same thing that a pilot goes through type of thing. So a lot to be said in that favor. Okay. And this was interesting type of thing as to how, surgery screening and all-cause mortality type of thing. And we talked about mammography type of thing. So as to, and we do make some difference, but, it's not all that it's cracked out to be. So there is controversy in terms of, how much do mammography has, people with low risk, have made a difference. Again, obviously, some of the other tests have been very useful, such as colon fecal hemoglobin test. But in the United States, the criteria is colonoscopy every 5 years or so. And so that's, but on the other side of the Atlantic, that is not considered as a normal recommendation. So depending upon, and even across the border in Canada, the recommendation may be different. So there is not general consensus when it comes to screening guidelines. So that's the point I wanted to emphasize. Okay, and there was an interesting that how in Korea, Korean surgeons and physicians were overdiagnosing thyroid cancer with ultrasound. Because thyroid is on an Adam's apple, and it's very easy to screen. So they were looking at the pathology and finding out the smallest tumor. And in the early 2000s, South Korea had almost a 15-fold increase in thyroid cancer. And they were promoting South Korea as a mecca for medical tourism type of thing. And then finally, we realized that we were overdiagnosing and overtreating some of these thyroid cancers. And these charts were, so these were some of the key points that they elucidated. Okay, let's see if I can zoom in properly. Okay, thyroid cancer is a disease, malignant cell forming in the tissue. Is found more often in women. Being exposed to radiation increased the risk, but it really wasn't worthwhile because it did not cause that many problems. So they were overdiagnosing. Similarly, Dr. Machi gives an example that when there are more CT scans available in a community, there'll be more nephrectomies, removal for kidney cancer type thing. And South Florida tops the things that they had the highest incidence of taking out kidneys because there are more CAT scan available. And a routine CAT scan sometimes shows, oh, there's a little blip on the kidney. So some of these things. And that becomes the problem with the so-called executive physical, because if you have something called the executive physical, you'll get CAT scan and all sorts of blood tests. And that lets me right into talking about, the so-called getting your genomic analysis. We talked at length about, doing genome analysis type of thing. That quite often we can diagnose diseases. Obviously some mutations are very useful, but many times we come up with VUES, variant of unknown significance. Means there is something abnormal, but we don't know what that is. And sometimes, the same variation can be, seen in many of the cancers, type of thing. So it again, so genomic analysis is opening a Pandora's box type of thing. So sometimes the point that we wanted to make sure to quote, to be cynical, to a man with hammer, everything looks like a nail. So more CT scan, fewer kidneys. You can just see. So that is, that's how the point is. Just I'm beating it to the death, so to speak. So not all cancer survival statistics can be misleading to diagnostic procedure. And we already talked about the over advertising with the K2 drugs type of thing, which prolong your lifespan for less than few days or even at the most 2 to 3 months at a cost and side effects that you occur. That thing. So overdiagnosis is a serious issue and especially in all the Western countries, not just United States. Okay. Now, again, now I have a few more minutes, so I shall carry on with my soliloquy. Okay. The two drugs which are of interesting to know, they both have relationship with breast cancer, the good and the bad, so to speak. Avastin was one of the biological agent, that was discovered by pioneering scientist who worked, was a basic scientist as well as a physician, Dr. Judas Folkman, and while doing basic research, he said that solid tumors have new blood vessel growth called angiogenesis. And they came up with an antibody that would block the abnormal blood vessel growth, prevent. And so initially it looked promising for breast cancer and was approved, but with larger trials, it was thought that it did not make a dramatic difference in testing. So it was one of the few times a cancer drug which was approved was the FDA withdrew the approval for Avastin. So it just goes to show as to how the preliminary studies looked very promising, but when used on a larger scale, it realized it did not make any difference. Now it comes out with the drug that is manufactured by a Swiss multinational pharmaceutical named Roche Pharmaceutical. And the same drug has been useful for a type of macular degeneration. And the ophthalmologists started using it in an off-label use, that they would have their own pharmacist mix it up and inject it into the eye for macular degeneration. But they made it harder and harder for ophthalmologists to manufacture type of thing. And they approved another drug, which is called Lucentis, which was smaller dose and marketed. The cost difference were anywhere between $40 when they divided up the doses, so to speak, to $2,000 that Roche marketed. So the games that pharmaceuticals play, so to speak, so that's the story of Avastin story. I thought that was eye-opening as to how the big pharma figures out a way to monetize. It was just a smaller dose marketed in a different way, more precise measurement, so to speak. And it wasn't that difficult to divide up the dose when assembled by a well-trained pharmacist. At the same time, more enlightening story was a human interest story of a biological drug, which is well known as Hertz receptor. A physician named Dennis Slyman ran into a biologist or a geneticist at a conference about a mutation that occurred in a gene in some of the breast cancer patients called Hertz mutation. And obviously, as some of you may know, the basic dogma is that the gene is responsible for protein, and the protein that is manufactured by these gene abnormalities, they came up with an antibody for this particular protein. And initially, the big genetic company, Genentech, was not too interested in developing this drug, but Dr. Slyman persisted and badgered the Genentech executives. This was done in collaboration with UCLA, so they were all the West Coast people. And finally, when one of the executives at Genentech's mother developed breast cancer, then they decided to put the effort type of thing, and they developed a drug called Herceptin. So the credit goes to Dennis Slyman, and he came from a really humble background. His father was a West Virginia coal miner, and so there was a drug called Herceptin. So now you'll see the ad about called the triple negative breast cancer that you see on late night television. Okay. And it was enough human interest story. There was a movie made out on his life called Living Proof. Okay, so it goes. So sometimes we take 2 steps forward, 1 step backward type of thing. So Judas Folkman, he relatively died young. Otherwise, he would have been a Nobel laureate. Not only he did work on this, but he also worked on the early days of contraceptives, pacemaker therapy, various cell biology type of thing. So there are varieties of people who contributed in multiple ways. Okay, I think we're coming up to 12 o'clock. Okay, and at the same time, something that is very obvious does not always work. All of you know about cholesterol, and there is something called good cholesterol, HDL. The higher the good cholesterol, less chance of heart disease. And there was about a drug that was developed, for raising the good cholesterol. It worked in laboratory, raised the good cholesterol and lowered the bad one. But at the same time, this adverse effects were dramatic, and it did not make a huge difference type of thing. So it increased blood pressure, more vascular side effects. So a drug company had bought the company for $800 million, and that was pulled from the market. So something that is very apparent in laboratory does not always work in vitro and in vivo, so to speak. Okay, I think, let me just go over a few images, then we'll stop. I think it's that way we can catch up with the next week type of thing, so Joel can have a floor. And the varieties of technology, we already talked about plain X-rays, 1901, then barium X-rays that some of you may have taken back in the 50s, the Brits with, the company that was started, with some funding from the Beatles. EMI Corporation was CAT scanning, and this is opened up the view, that thing. And then positive emission tomography, later on MRI, magnetic resolution images, which is the principle of MRI is extremely complicated, and I'm not even going to go into it. There were about 7 Nobel Prizes awarded for MRI scan, magnetic resolution images. So initially it was called nuclear magnetic imaging, but the word nuclear was no. So that's why the name was revised to magnetic resolution. And this is the technique that is ultrasound. And, and now there is even further magnetic imaging. Let's just show a last video type of thing, and then I'll let you guys off and stick around.
Well, why do we want this scanner? Well, this is what the machine can do. This is not a simulation. This is a real patient. We scanned this patient, their entire heart, their entire aorta, the chest, the abdomen, and the pelvis in 9 seconds, and produced this level of detail of the fine arterial anatomy throughout the entire body. I call these eye-popping, eye-candy images, and they're truly impressive. The diagnostic power is amazing. If we concentrate just on the chest, here's the aorta, and also the coronary arteries you can see as they rotate. This patient we were particularly interested in because they had an anomalous vessel down here, which went into the lung. But you can see the extent of coverage and the detail is produced, and in this particular case, in 6 seconds. Dr. Goldberg talked about carotid disease in the neck. We know that you get plaque in the neck, and that leads.
Okay, so you get the idea. So this is, so the technology has made dramatic difference in the modern medicine type thing. So we owe a lot to the silent heroes, i.e. engineers, who have made our life a lot more simpler. But at the same time, CAT scanning, it's almost getting like, flying for 500 hours. So you get a lot of radiation with that. So so that's why I think taking a CAT scan of all your bodies, your physical, is not the greatest idea in the world. So I shall stop here now, and I'll stop the recording and stick around for any questions type of thing and comments. Okay. So I think I talked like an auctioneer, but I think we have a lot of material to cover, and we'll give Joe time to share whatever he has to say. Okay. All right, folks. Okay.
I think
Okay, now send out the recording as usual type of thing.